Hello, everybody. We are back. I hope that you've missed us because we have missed you. Welcome back to Curated Conversations. This is episode 4. Very special episode for us today. Curated Conversations with GRAAHI. We're your hosts. My name is Kaylon.
I'm Calvin. Hello.
You see it. You see it. So one thing we understand is that health can be a daunting topic and discussion to tackle alone. Curated Conversations is a podcast by the Grand Rapids African American Health Institute, where we focus on our models of care: community, advocacy, research, and education. And through that model, we hope to benefit the community in which we serve. Come along for the journey as we take a deep dive into health topics alongside you.
You really are that good, huh?
I really am that good. Internal joking between us, I kind of flipped the script a little bit, and that was just off the top of the head. You know what I'm saying?
Love that.
Shout out to my guy, Lil Wayne. You know what I mean?
You know,
Get you a culture today. Like I said, is a very special episode. We want to introduce you to Dr. Darla Bishop.
Hey, everybody. I'm so happy to be here.
How are you doing today?
Oh, I'm excellent 7 days a week.
Good.
Hey.
Let me tell you, she's been smiling since we've met earlier today.
I'm a happy person. I have a good life.
That's good to hear. That is a blessing. What are we here for today, right? Today, we're going to take a deep dive into a topic that affects most, if not everyone. And those topics are insurance, health insurance to be more specific. And we're going to teach you about a little bit of the background history of, where insurance kind of came from. And then, why was there a Medicare and Medicaid, and some of the risk and benefits that are involved with both insurance policies, I'll say. So again, we thank you all for being here. Let's get this thing going.
Let's send it off. Perfect. So to start it off, obviously, I think it makes the most sense for Dr. Darla Bishop here to give us the scoop. 5 minutes of who you are as a person, your professional career, all that. Yep. Whatever you can squeeze in 5 minutes.
Ooh, 5 minutes. How about?
Hey, we'll give you 10 if you need it.
That's a lot, actually. You know, I'm working to not talk so quickly so that people can keep up, because sometimes I talk fast. So, Hi, I'm Darla Bishop. I'm originally from Detroit, currently living in Lansing, Michigan. I have a doctorate in public health, where I studied some very specific payment models in Medicaid. Now, I just got this doctorate about a year ago, but I'll have it forever.
Ain't no just got. She's a doctor, baby. Let's go.
But I'll have it a
Life
year
and
ago.
legacy.
Yeah.
Life and legacy.
Put it on the tombstone.
That's right. But I'll have it forever. So that's all that matters. But how I got here is growing up in Detroit, we had our share of all types of good and not so good times. And I do remember that we had Medicaid at some point. And at that time, Medicaid came on this you got this little blue piece of paper, with that printing on it. And it just had your name, your date of birth, your address. And it said, Darla, Medicaid, and then had like a little checkbox if you were allowed to go to the dentist. And I remember getting ready for school one year and needing to get our eyes checked, because they said, oh, please go get your eyes checked before school starts, because we won't do eye exams until later in the year. We want to make sure your child can see the board. And us going to either 2 or maybe even 3 different eye stores, the ones you see everywhere. I don't want to mention names because,
right. They're usually somewhere up the street, or a friend knows of them. You can point to it when you're driving past,
right. Or it might be inside the mall.
100%.
But us having to go to like 2 or 3 different of these eye stores to find one that would accept our Medicaid, just so my mom could get a really simple eye exam done for us kids.
Right.
And I remember thinking like, well, that's not fair that we've had to go to all these places just because the test only took a few minutes.
Right.
It's like, okay, look in this thing. Which colors do you see? Can you see this dot? Name the animals. And then I also remember once we finally found the one that would accept our little paper Medicaid card, my sister, it turned out she did need glasses. And, in those stores, they have the like 3 or 4 big walls of all types of glasses, right? Different shapes, different colors. And they usually have a little smaller kid section with like fun stuff like pink and purple, or they have like a fun shade.
Looks like somebody customized them themselves.
Yeah.
I've seen that.
And I remember my sister getting so excited to go pick out her glasses, because I think she really wanted to wear glasses. And they brought us this little box of ugly frames that we could get because we had Medicaid. And I remember my sister being like, well, at least they have my favorite color. but I could tell that she was disappointed because she was like actually really excited that she was able to get glasses. And I don't know if she was excited because she just thought glasses were cool or because she really couldn't see. Yeah. And so she was excited to be able to see.
It's almost like you're getting these lists of options as if these are really your only options. And it's not being told to you that this is really just based off of the insurance that you have right now.
You know, and this was, 25, approaching 30 years ago. So I don't know that we were thinking like that. We're just like, oh, man. Like, we were excited to get glasses and we only had a couple options, right? And so that made an imprint on me, right? I can still tell you the story. I remember the feeling of being in the store and like having to take a bus to get to a different store because that store couldn't take our insurance, right? And so when I went to college, I thought, because you only give kids a couple of options, like, what do you want to be when you grow up? I'm going to be a doctor because I knew that was going to be my way out the hood, right? I was going to be a doctor. 100%. I wasn't good enough at arguing to be a lawyer. So I was like, oh, well, I'll be a doctor. I've got bad handwriting and everything.
I was looking into being a doctor, too. They told me how many years of school, and I was like, that's why they're doctors.
Yeah. That part didn't scare me. So when I went to U of M from Detroit, U of M Ann Arbor, go blue, I was taking organic chemistry. I was having a real hard time. And one day, after leaving that big lecture hall with probably 200-300 students, I saw this table on the diag. I don't know if you've ever been to the U of M campus, but most campuses have this kind of spot somewhere in the middle of the campus where people have to walk around and they do festivals and they have tabling. And on this particular day, there was this Public Health Student Association. And I was like, oh, I wonder what that's about. So I go up to the table and say, oh, what is the Public Health Student Association? They're like, oh, we're students who are interested in public health. And I was like, oh, well, I'm pre-med. And they were like, oh, we have a lot of pre-med students because the cool thing about being a doctor is you get to help patients and their families, like one-on-one, really help them get their health together, recover from an illness. But when you're in public health, you get to do that for whole communities and countries. And I was like, oh, I can do that's let me sign up.
Scale impact is really there.
So whole community,
right?
I want
not just persons.
I want to do that. So then I joined the Public Health Student Association and decided, like, okay, I'm going to be a public health person. I don't really know what that means. And when I told my family, they're like, what you mean you're not going to be a doctor? I said, well, don't worry. I'm still going to work in health. It's just now I'm going to, change the health of communities, not just individuals, not just families. And so they came along. I went and did a master's of public health focusing on health education, and then did research for a few years and had the opportunity to move to Washington, D.C. and work for Senator Stabenow, who's actually retiring soon.
Oh, wow.
And worked in the Senate at a time that the Affordable Care Act was causing a lot of trouble.
Oh, wow. It was a busy Congress. Time then.
Yeah, to the point where we actually had a 13-day government shutdown because of some of the provisions of the Affordable Care Act.
What year was this?
This was 2013.
Okay, I remember this because I was going into the military or looking to go into the military at that time. And I think when there's a nationwide shutdown, military people were not getting paid.
That's right.
So there was a time where I was walking in my recruiter's office and everybody was stressed out.
Oh, yeah.
It was a super stressful time. But that's just goes like it's so many layers that can get impacted just through public health that's right. That even connected to me at that time. So it's interesting to think about.
Yeah. And so at that time, I was actually working as a lowly intern. Even though I had a master's degree, I was new to DC and it was just looking for a way to figure out DC because DC is so different than any place I'd lived in Michigan in terms of what it means to work there, what it means to be a professional there. And even though I had all this education and skills, I just wasn't exactly sure where to take them. And so thanks to networking, someone who I knew from college was like, oh, well, I work in the senator's office. If I can be helpful to you, let me know. And I was like, actually, could I be an intern? She said, yeah, but internships are not paid. I said, I think I can do that for like 4, 5, maybe even 6 months. But like, where else could I get this kind of experience? And I happened to be in a stage in my life where not making a main income, because I always had 2 or 3 jobs at that time, like was going to be okay. I was like, well, I got my waitressing job, I can do this on the side. So like, yeah, I if you think they'll let me be an intern, I'll go be an intern.
I want to sit in this moment for a minute because even for me, I don't have a degree. So I had to kind of look at life like, where can I invest my time and my energy to get around these people and spaces? And even for the young people that are out there listening, you know, there are maybe opportunities that present themselves that can be investments into your future. And it's not always tied to the money, like you said. So it's kind of like something to think about. You know, if you are young or just in general, you're trying to get into those new spaces, it's okay to align yourself with the people and spaces that exist.
That's right. And, you know, I had a professor who told me there's two ways to say it. Network is your net worth. So who you spend your time with, who pours into you, who you spend your energy around is what helps to determine how much money and resources you have in your life. But also network or not work. Because when you have good relationships with a lot of different people working in a lot of different places, then when you get into a situation where you've moved into a new city and you only know a few people, that could be exactly the thing you need to get that first job or that first internship or that introduction. And so don't be afraid to remember people's names and where they are and what they do.
It's the little intangibles and pieces. It's also like those small connections that you've made. You could have met somebody at the gym and then ate lunch with them, you know, their family. This person works in a whole nother state, in a whole nother industry. Like she said, never be afraid to reach back out and say, hey, this is what I want to do. I don't even know if you can help me, but I want to put myself out there.
Yeah,
absolutely.
And you also never know where people will end up. So you might have met them at a point where they weren't doing much. You know, like people who knew me at that time were like, oh, okay, you're an intern. You're an unpaid intern. Okay, well, I'm a doctor now.
Hello. And that's part of the whole story. And that's where the point now, like, I feel like, you know, you set the tone for this entire podcast. And the tone that I want to actually identify is passion. And as well as passion is the persistence to believe in yourself, to know, like, you know, your value, your birthright, as Vanessa, our CEO, always speaks to, knowing your birthright and working in that. So I want to say kudos to you, and to see where you're at right now is even inspirational to us. And I'm sure for those that are watching, you will see Dr. Bishop's information here. So never be afraid to reach out to anybody. If they're inspiring you,
for sure,
reach out. You never know what can happen. Put yourself out there and live in your birthright 100%.
So I do want to mention that I am a member of the GRAAHI board. And part of the reason I kind of volunteered, squeezed my way in, found Vanessa and was like, do you need a board member? I saw you had some openings, is because I really care about the health of communities, especially communities where Black and brown people live. And part of that is because of my experiences living with Black and brown people and having those little hints that we could have a different life. We could be healthier. We could be happier if we just had a little bit more resources, if we just had a little more knowledge and then knew what to do with that information.
With that knowledge, right.
Right. And so that's why I wanted to be a part of what GRAAHI is doing, because of the more than 20-year history of what the organization has done, not only in Grand Rapids, but in Greater Kent County and around the state.
Yep. And that's where we appreciate you sitting on our board. You bring a lens and an insight that's needed and appreciated in the community. So when you're seeing these programs and things running and they're coming out of the GRAAHI, it takes a family, as we call it. So even with Dr. Bishop sitting on the board, she's taking a look at a lot of these projects and really pushing us on the ground to make sure that it's really going to benefit everybody that we're serving. So I just want you all to know that you may see us in the community, but we're a byproduct of Dr. Bishop's thoughts and plans and energy as well. And it flows just like that. Where I do want to shift now is kind of getting into the meat and potatoes of why you're here. And that is the daunting topic. And I call it daunting because that's what it is.
It's
even
daunting.
For me. I've had insurance for a long time, but if somebody asks me a question about my insurance, you may not get an answer. I'm going to tuck my tail. I'm going to tuck my tail.
Let me tell you.
I don't even know sometimes.
Let me tell you a little personal experience I have with insurance. Right?
Run it. Go ahead.
One of the scariest moments I had in my life, I think, was my 26th birthday. You know, having to figure out my own insurance coverage and all that stuff. Yeah, literally. Obviously, big appreciation to my parents, you know, taking care of me and having me under their insurance and stuff like that. But, I mean, a lot of those nuances and information about insurance in general had made no sense to me whatsoever. because I'm like, mommy, I don't feel good. Can you call the doctor?
I'll set the appointment. Just go at this time. Don't worry about it. Make sure
you bring $15 to pay for that copay. You know what I'm saying? So that's all I ever knew about like what health insurance really was. So just the fact that, I mean, I would consider myself a relatively knowledgeable person, or I like to think so.
Dr. Bishop, I'm going to cut him off because he says a relatively knowledgeable person. Calvin is the type, when we're driving on lunch and he looks at a building, he's like, did you know that building used to be something else back 20 years ago? Did you know that they changed the bricks on that back in 1955 and now it operates like this? He literally knows everything.
Okay. Now I have to ask you a question.
Checker.
Now I have to ask you a question. Okay, I do the same thing, so that's why we get along so well.
Yes. Okay.
Okay. Did somebody call you a know-it-all as a kid?
All the time.
Okay, so that's why.
Good Lord, all the time.
That's why.
Yep.
So when I was a kid, somebody called me a know-it-all, and I remember thinking, I had to be 7 or 8 because that's where I feel like most of your memories as a kid kind of start, right? Unless people showed you pictures, then you have some artificial memories, right?
True.
So like I had to be 7 or 8, and I remember being like, "You're right, I am a know-it-all. I like know lots of things. I'm gonna always know lots of things."
And y'all just love it too. Y'all just bathe, y'all bask in y'all glory too. When y'all see something and that little thought, I can see it in your eyes. Where it's like, oh, ping. Yeah. I'm about to tell them something.
It's nothing like getting a fun fact off. It's like, ooh, fun fact.
Fact.
I call it dad mode for him. I said, you're going into dad mode. You're just telling me about weather and random facts. Like, you want us on your trivia team. 100%.
Oh yeah.
I ain't going nowhere. Any road trips or anything, y'all will keep the conversation.
Yeah.
So I love that.
Yeah, and to go back to Calvin's story, what's so interesting about your story about turning 26 is had you come of age just a few years earlier, you might have been doing that at 18 or 21 for the Affordable Care Act that extended that to 26.
That is true.
Wow. That's crazy.
And because that's how we've been living for the last decade.
Exactly.
We don't remember that.
Yeah, it just flies over our heads.
You don't even know about that.
I didn't even know that was really a thing until later in my life. After I was like, same thing. My mom's like, you're lucky that you could be 26 on this plan.
Exactly. And still have it. I remember my dad was still telling me too. He was like, man, listen, I know you ain't got it right now, but I was planning on you to be off my policy. Because my dad was still paying my copay.
Oh, yeah.
Oh, thanks, Dad. Shout out to your dad.
Shout out to Pops. Shout out to Pops. Love you, dude. So we kind of want to talk about where did insurance, even the thought of insurance, even come from? I mean, for me, I see myself paying this money every single month. Going into a pot. Like, how did this start and why did it start?
Okay, so let's talk about how health insurance in the U.S. started, because insurance as a concept has been around for a super long time. And so let's talk specifically about health insurance and in the U.S. context, where essentially a group of people, and the story I want to tell that my favorite is to tell is a group of school teachers in Kansas. So imagine, 100 years ago, folks getting most of their care from a home visiting doctor, right? There are hospitals, but they're kind of rare, they're kind of new, they're kind of small. So most of your care is coming from a doctor who is doing house calls, coming to check on you. You call the doctor, you send somebody on a horse to let the doctor know you need care. The doctor comes back on a horse. And so this group of school teachers had a coworker who'd gotten really sick and so wasn't able to work. And there weren't any social insurance programs yet, right? No Social Security, no disability benefits, no health insurance. And
that methodology wasn't even a thing for the community to kind of even grasp at that point.
Right.
Wasn't even happening.
And so communities just did it on their own. So this group of school teachers said, well, we know that, so-and-so can't work. His family still needs to eat. His family still needs to be able to live while he recovers, hopefully, from this illness. So what if we all put a little money in to help pay the doctor, to help give his wife a little money so that she can, buy food for the home. And then they were like, actually, that worked really well. So what if we just all do this all the time? Every month from our salary, we'll all put a little bit in the money. And then if somebody has a need because of their health or an injury, they can take out without being worried that they're going to just ruin their situation.
Right.
They won't be able to live. Their family won't be able to survive. And, that they might have that time without working where they're not making any money. They still can get their basic needs.
Yeah. While being stressed. Ultimately,
yeah. And so it really is this social contract where people are coming together, putting in a little bit of resources on a large scale so that when someone has an illness or injury, they can go to the pot, pull some money out to take care of that illness or injury. So it's really beautiful.
That is. And back in that time, it had to be a lot of trust involved there. But you also knew, though, like, if I do take from this pot, I may not have nothing if I want to take care of my own health itself. So to have the trust there on a community perspective is good to see back then. So here they are putting this money into this pot, and everything's kind of going well, I assume, for them to then keep this process going for a longer period of time.
And then as things kind of grew and got more advanced, and, you know, depending on your perspective, then it's like, well, we can, instead of just putting kind of in the pot that Mary keeps in the schoolhouse, we can, you know, start to just pay a hospital or pay a doctor. We'll give him the pot of money so he just can pull from it when he needs to, when one of us needs
and cover all of us.
And then, you know, fast forward 100 years, we've added all types of complications and enhancements and things to make sure that insurance is doing what it was intended originally to do, which was basically help a lot of people without a big cost to each of those people individually, so that in case of an illness, an injury, even sometimes in the case of death, when we're talking about health insurance, that they don't face financial ruin. And then Medicaid and Medicare specifically was a major legislation in 1965 as part of the Social Security Act, which had been attempted earlier in the 40s on the heels of the Great Depression, because elderly were so much more likely to be indigent, to be unable to work, unable to care for themselves, and to be highly dependent on their adult children for their very basic needs. And were also people over the age of 65, again in the 1940s, were also the largest group of people using hospital services, which were really expensive services.
That's where that Social Security needed to happen to cover them in that basis when they hit that age range or risk range for them at that time.
For their health.
That's interesting.
And so in the 40s, it didn't get enough social will, political will to pass. But with all of the civil rights movements of the late 50s and early 60s, there was an opening to where there was a conversation around, well, what do we need to do to make sure that our most vulnerable populations, up to and including Black people, up to and including immigrants, up to and including our elderly, have some safety nets so that we can be in a better place in the country. And that's where Medicaid and Medicare came along.
Really?
Where it was a healthcare program for the elderly, Medicare, and a healthcare program for low-income Medicaid.
100%. That's a great way to lead us into our next segment, where we're going to actually go into Medicare and kind of dive into, you know, why you need those policies and the risks that may be involved and what can let you know is a good policy. So
we really appreciate you kind of giving us the Insurance 101, for lack of better terms. There's a lot of things I really didn't know in terms of how all of this was even conceptualized, you know. So just that idea of the communal aspect, like looking after your neighbor. I guess I'm really glad that's kind of how insurance started off. You know?
Shout out to them teachers, man.
Because sometimes when you're dealing with the harder parts of it, it's like, why is this so hard?
Exactly.
It started off really with
really
good
pretty simple,
really super good intentions.
Exactly. So that's good to know.
Hey, so the government isn't preying on us. You know what I'm saying? It actually started off.
Now, look, we all have a healthy dose of conspiracy. Me too. But we're not doing that today.
Not right now.
Exactly. We'll keep it.
We'll keep it honest. I've always wondered.
We'll keep it like that. But like I said, we dove into the Insurance 101s about where it came from, how it kind of got brought around. But before we dove into Medicare, I wanted to talk a little bit about just the overall types of health coverage that the general public has access to and should know about. Yeah.
And so in the U.S., we have a few different kinds. So we have what are sometimes called commercial or private insurance. So this is the insurance that you get because you go to work and your employer gives it to you. So these, I won't name the different names, but basically this is, you know, an insurance company has made an arrangement with the company that you work for so that as part of your benefits package as an employee, you get access to health insurance coverage. So those are usually called commercial or private. Okay. And that's what most people in the U.S. have, either through their own job, through their spouse's job, or through their parents' job. Then there's a different type, which are government programs. So this includes TRICARE, which is a medical insurance program for people who are in the various military.
That's your boy.
Yep, right, TRICARE. And then there's also Medicaid, which again is for low-income individuals and children. Lots and lots, millions and millions of children are covered by Medicaid in the U.S. More than 50% of the births that happen in the U.S., that happen in a hospital setting at least, are paid for by Medicaid. And then there is Medicare, and that is the health insurance program for the elderly, so 65 and up. There's a few different ways that you can qualify for Medicare if you're not 65. There are certain health conditions that the government knows are expensive to care for, can really put you at financial risk if you don't have help to manage those conditions. If you are 65, you do have to be a U.S. citizen or permanent resident. And so you do have to have some legal immigration status. You have to have worked or paid into the Social Security system for 40 quarters, which breaks down to basically about 10 working years. And so the reason they broke it down in quarters is when they were first putting together the law that underpins Medicare and Medicaid, the Social Security Act of 1965, some really important advocates says, well, what about people like farm workers who are the backbone of this country but work seasonally? They absolutely work for more than 10 years, but if you're only counting it in year blocks, we might leave them out. And so that's why it's 40 quarters, which again adds up to 10 years. But it might be spread out for someone who is a seasonal laborer or a farm worker over the span of 20 or 30 years to have paid into the Social Security system through their employment taxes. Right. And then if you are not 65, you can also qualify for certain health conditions. The main one that most people know about is like end-stage renal disease. So those are folks, folks who need to be on dialysis because they have a kidney disease.
Or another like qualifying disability in a sense that they can do. I think I learned that in the nursing home that I was working at. And a lot of individuals utilize their Medicare plans. There's a split in there though. It's like Medicare A and Medicare B.
It starts getting
a little.
We'll get to the alphabets.
Okay. Well, let's wait to get there. In my eyes, how does someone that's 65 choose, I guess, the right plan, or are they choosing Medicare before they're 65? What is that process?
Let's only talk about the 65 and ups, the main people, the biggest group of people who would have Medicare. And so when you're getting ready to turn 65, the government, usually the Social Security Administration, so the same office you go to get your Social Security card, will send you a letter in the mail that says, happy birthday, you are turning 65, usually about 3 to 6 months before your 65th birthday, to say it's time for you to officially retire because according to the Social Security Administration, you are retiring and that is what's making you eligible for your Medicare at the age of 65.
Gotcha.
And so you get this packet in the mail that says, your birthday's coming up. It's time for you to choose your Medicare plan. And Medicare, we are going to get into the alphabet. So Medicare has a few alphabets: A, Part B, Part C, and Part D. So A is your hospital coverage. So this is the part that allows you to go to a hospital, have that care paid for with a small portion that you are responsible for out of pocket. It's usually somewhere between the 20% mark that you need to pay. So Part A and B is you get like a little red, white, and blue because it's like straight up. It's just the straight up government Medicare program. And so Part A is the hospital. Part B is your physician and medical services. So the Part A allows you to go to the hospitals for whatever care, for surgeries, for, important tests. Part B is what covers you when you go to see a doctor for, routine visit, for a checkup, if you're managing a health condition, for those appointments and related labs and stuff like that. And then some drugs, so some prescriptions are also covered under A and B. For instance, if I had to go to the hospital for a surgery, any of the medicines that I needed while I was in the hospital would be covered by A and B because they are associated with me going to get that surgery done and recovering from that surgery. Now, if I have medicines to manage my diabetes or my HIV, those may not have as good coverage as the things that I needed while I was in the hospital. And so that's why we have Part C and Part D.
Okay.
So I'm actually going to skip a letter because D is the part that you can either add to A and B. So you can have A and B, your little red, white, and blue card straight from the government, plus D, which is for drug coverage.
Okay. Gotcha.
And that's basically saying, hey, I know I have some medicines. I have a heart condition. I have to manage my diabetes. Maybe I'm a cancer survivor, so there's medicines I have to take to keep my body working well after recovering from cancer. And so I know that my prescriptions would otherwise cost me a lot of money, too much money, especially because I'm retired. I'm not earning any new money.
Right.
I'm living off of a pension, which are now getting more rare, or I'm living off of Social Security benefits and I'm on a fixed income. I don't really have a way to increase my income. So you can purchase a Part D plan to go on top of your A and B plan to help reduce how much you have to pay out of your pocket when you have prescriptions.
How much does usually like adding a range, or how much would that usually cost an individual that wants an ad? I'm pretty certain that it changes as the years go on, but is that like a huge cost that you should kind of be looking ahead for? Or?
I'm so glad you asked about the cost. So the cost does vary on state, on region, on your health conditions that you already have.
Okay.
And so what I will say is that if people can do a little bit of math, which I know math isn't everybody's favorite subject.
Definitely not mine.
But like if you looked at the real cost of how much your medicine costs, which most people actually don't know how much their medicines cost because they're so used to paying a copay. Because again, I told you earlier, most people get their insurance through their job or someone in their household's job. And so with that kind of insurance, you go to the doctor, you go to the pharmacy, and they say, great, here's your medicine. Your part is $10. Your part is $20, right? It's kind of a flat, consistent amount. And so you might not realize that the medicine you've been paying $10 a month for, actually, if you went to that same pharmacy and said, oh, I'm just going to pay with my debit card or write you a check, because we're talking about 65 and up, they might still write checks.
Farm is eating.
Right? Then that medicine might actually be a $200 medicine.
Oh, wow.
And so it's one of those things where it's like, okay, if I take a few medicines every month, and what is the real cost of those? Even if the Part D plan cost a few $100s per year, it's probably still worth it. Right?
Outweighing, and that's what she's saying, right? So she's saying if you know you're looking at your medications and, you know, before you become 65, you're being covered and you're paying this out-of-pocket cost of $20, when you switch over to that Medicare, you kind of want to be a little bit more thoughtful of what your prescriptions may actually be costing you. It may save you a lot more money to just pay that Medicare D add-on fee to save you all of the money on the back end.
And it's literal insurance, right?
Literally.
It's also literal insurance, right? So because I have these health conditions today, but something could happen, right? I'm older. I'm not as physically active because I'm not going to work every day. Depending on your lifestyle, people have all types of ways that they live their life in retirement. But there are just some things that happen to your body when you're no longer working, when you're less active. Maybe you're not eating as consistently. And so your health conditions today, before you retire, might be really different just 6 months after you retire. Things that maybe you ignored that were kind of under control because you were working, you were out, might pay attention to that, that soreness, that pain, and go to the doctor and say, oh, I'm so glad you brought this up. We can actually solve that problem, but we got to put you on a new medicine for a few months to solve that problem.
Gotcha.
Right? And so what adding something like a Part D does is it's literal insurance in case your health changes, which when you're over 65 is like
going to
more
likely
to happen than when you're 22.
Right. Things are pretty much, because you can lean on that youth. As I would say,
for a long time, and many of us do.
I'm leaning hard. I'm leaning real hard. You hear me?
But when that big 30 comes, make sure you start eating a little more vegetables. Make sure you start drinking your water.
Hey, the basketball games be a little bit less frequent.
Or keep doing it, but put on your knee brace to protect your joints.
There we go.
Speaking of knee braces, make sure you go out and purchase some really good equipment, whatever you need to keep your body healthy. That's a good investment.
They say act your age, not your shoe size, right?
Yeah.
You know you're getting up there.
Oh, I love Prince.
Make it, you know.
Time to make it make sense now.
Make it make sense, man. Put on the ankle brace. You're not you're not too cool for an ankle brace.
You're not too cool for the ankle brace. Right. Because really, when it comes down to it, you really only get one of these. You are issued one at birth.
One and done.
That's it.
You
and
ain't
so
lying.
you got to do your best to take care of it as long as you can. And health insurance is something that as a society can really help us to take care of our health.
And that's one of the things we were talking about, like when it comes to the benefits of having insurance in general. It really can subside your stress levels.
Yes.
Knowing that that's there, especially when you get into that age where, you know, things become a lot more volatile. You know, a fall can kind of offset your trajectory at that age of 65. Right. So being a little bit forward thinking, that's why Dr. Bishop, you being here is just important and so relevant to what's happening today, to make sure that you're looking at your plan and the benefits that work well for you.
And open enrollment season is coming up. It's usually sometime in October till November. And so I'm glad we're having this conversation now, because people can start thinking about it, start asking questions, start looking stuff up on the internet. We didn't do because remember
we didn't do part C yet.
So we gotta do
I got
C.
part D still. I got a question.
Okay.
Can you add on part D at any point in time in the year, or is it only in that open enrollment season?
Only in the open enrollment
season. So in
October, you do get a chance once every year.
Okay.
So say it's your first year, you're like, I'm healthy. It's maybe you turn 65 in November. And so you're like, I'm good. I'm good. But then the next year, so you do have an opportunity each year to add or
and that's
subtract.
When it's time to start taking that inventory. And that's why I asked the question, because it's important to know that around that fall time to start taking that personal inventory and get what you need when it's that enrollment time.
Right. And when it comes to Part D, just because you have it this year doesn't mean you'll have it next year. So you do have to at least look every year during that enrollment period, because some plans, and they usually spell it out, because there are also some really good rules, regulations, and laws around how we have to communicate this stuff to protect seniors from making a mistake that could be costly, like not only to their finances, but to their life and their health. And so it usually says like in the front page or the cover page of your coverage document, it'll kind of tell you this policy automatically renews. So it'll tell you whether you don't have to do something, and it'll just automatically turn back on, and they have to let you know if the price change, or it'll tell you this plan does not renew. You must take action.
Gotcha.
And so right on that first couple of pages in their plan guide that they should receive about their Part D, it will tell them whether they can kind of chill because it'll automatically renew, and they'll just get a letter if the price change, or if they need to take action.
To actually do that.
But once a year, when they start hearing the commercials, when their friends at the senior center start saying, hey, what am I going to do about my Medicare? They should say, oh yeah, let me look if there's something I need to be doing.
Moral of the story is review the policy. You know, review your policy.
The documents.
And like she was saying, you don't miss out on the opportunity, because you always can do it next year. But be well prepared. Obviously, this episode should roll out well before open enrollment comes around. But do the due diligence. Look after your policies. View your policies year after year to ensure that everything is still up to date with what you're expecting from your coverage, and then following through with that process throughout the year. So
100%. Right. Let's get to C. We've covered A, hospitals, B, physicians.
And those come together.
And those come together. That's natural by default when you turn 65, right? D is an add-on option for drug or prescriptions that can help you offset it if you are seeing yourself having to take a lot of prescription drugs. Now let's get into C. What is C about?
So C is Medicare Part C. Looks a lot like the health insurance most of us is used to. Okay. It's where the government has said, we know that so many people are used to having their coverage through a private company because that's how they had it when they were growing up, when they were working people. And so we will let the same companies who offer it to employers offer these Medicare plans. They're called Medicare Advantage. And what it does is it looks a lot like the plans you might have had when you were working, where it kind of packages a bunch of things up for you and gives you a flat copay.
Gotcha.
So with the Part A and Part B, you might have heard me say copays were percentages. So that's like really different, right? You told me when your mom used to make your appointment, she'd be like, don't forget your $15, right? That's a flat dollar amount.
Right.
So with the commercial insurance, you're used to that dollar amount, $10, $15, $20. If you had something big happen, like an emergency room visit, might go a little higher, like $75 or $100, but it's a dollar amount, a fixed dollar amount. With Medicare A and B, it's a percentage.
Right.
And so that can be a real change for people who are like, oh, no, I got my $15. Well, ma'am, actually your visit was $300. So 20% of $300, you need to bring us $60.
Right.
Oh, oh, I didn't think about that. So what the Medicare Advantage or Part C does is you purchase it through a company and they package it to something that looks a lot like what you probably had if you were a working person or had insurance from someone in your household who was a working person. And so it's kind of has that same scheme where it's like it includes some doctor's visits, includes some hospital stuff, includes some surgeries.
Let you know what you're accounting for, what their dollar amount
is, and includes some drug coverage as well.
Why would someone that has A and B and I've added on D, why would I need to go and look at C?
And
like,
so,
what's the benefit of being looking at that option?
And so the reason it's good to look at it as an option is because if you've had a certain kind of health insurance for 40 years, you kind of know how it works, right? Right? When you go to the doctor, you show your card. When you leave, you pay the $20. And so changing from going to the doctor, leaving, paying your $20 to going to the doctor, getting a bill for a percentage,
that's
especially
the key
now
point.
that you are not probably working or not working at months and you are now on a more fixed or even a lower income, then that can really throw off your month-to-month budget, especially since what you're getting in as a non-working person is probably not going to change all that much.
Right. Okay. And that's where it helps your financial just astuteness. You're able to kind of stay on top of things as you were before. So it doesn't add too much new things to your plate when you turn 65.
And maybe you had, certain doctors that you really, really have worked with and they really know you, and maybe they just prefer to work with that insurance company, and so you can buy the plan with that insurance company because they like working with them. It's easy for whatever you need to get approved and to be covered. Then it's a really good option. Now Part C, it kind of does this cool thing where it combines A and B together and makes it look a lot like what you probably had as a working person.
Right now. Okay.
Now there's also a way that you can say, okay, Part C is pretty good, but I need more drug coverage than that because, again, maybe you are, as a 65-year-old person, having to manage some health conditions with medicines, and that's fine. Look, I'm going to actually take a small commercial break here and say, I know the people in my family frequently will say, well, I don't like that medicine.
Right.
I don't know if the doctor gave me the right medicine.
100%.
I'm not taking that
Sound
medicine.
like my granny right now.
Oh, so you've heard this?
I've heard it. I've definitely heard it. I'm hearing her voice right now as you speak.
So I'm going to pause and say, look, if you are on a medicine and it is not working properly, first ask yourself, am I taking it the way that my doctor actually told me to take it? Because if you have a blood pressure medicine that you're supposed to take every day, and you take it only when you don't feel good,
when you get a headache,
or when you get a headache, guess what? It's not doing what it's supposed to do, but because it's not in your system every day to actually control your blood pressure. You're using it like an aspirin, where, oh, I got a headache, let me take a medicine. But blood pressure medicine doesn't work like that. It has to be in your system to help the systems that are a little bit out of balance be in better balance so your blood pressure doesn't get high in the first place. Right. So the first thing is, if you're one of those people who's like, well, I'm not taking that medicine and you're not feeling great all the time, ask yourself,
am I really on the regimen?
Have I taken the medicine the way my doctor told me? Okay. If you ask that question and the answer was like, yeah, I took the medicine the way the doctor told me and I still don't like the way it makes me feel, or I feel like my blood pressure hasn't been controlled. I'm using blood pressure as an example because I think it's an easy one for people to understand. Then guess what? You go and talk to your doctor and say, this medicine isn't working. I've been taking it the way you told me to, but it's making me feel weird. I'm still getting headaches. And you need to figure out if I need a different dose, a different kind of medicine, or if there's something with my diet because I'm not feeling good in my body. We talked about how you only get one body. Guess what? The only person in your body is you. So you have to tell the people who are helping you to care for your body when something doesn't feel right.
Right. That's knowing what.
So I'm ending the commercial break about like the folks who are hesitant to take their medicine. So please take your medicine as directed. And if after taking your medicine as directed, the reasons you were given the medicine are not improving, then you tell the people who gave you the medicines that it's not improving. You need them to do something about it.
And that's okay. That's what you should do. You're not offending anybody in the room. You're not being extra. You're not being boastful. You're not being anything negative. You are being an advocate for your health, which is the biggest and the best thing that you can do for yourself and your family. So I appreciate your commercial break.
And after developing a relationship with your PCP, this should be a natural and encouraging conversation to have with them.
100%.
And if, maybe you don't have a doctor's appointment coming up to anytime soon, maybe you're not sure, another really great person to ask is your pharmacist. Pharmacists are such an amazing part of our healthcare system, and they're so knowledgeable, and they deal with these medicines all the time, that if you have something that's a little bit off, you can actually ask the pharmacist, the person who handed the medicine to you when you went to pick it up, and say,
And I was going to say, would they, like, even speaking to a pharmacist, I had to do this recently. They can actually look at the medications and what's really matching with your insurance and the costs that are really, like, they can really speak to those numbers. Never be afraid to go directly to the pharmacist, like Dr. Bishop is saying, to get the information you need spelled out for you.
That's right. And the other thing
that
that's so great about a pharmacist too is they can see all the medicines you filled up for the last 2 or 3 months. So they might say, well, Dr. Bishop, I'm actually noticing here this month you filled 2 blood pressure medicine. Are you taking those both? And I can say, well, you gave them both to me. But that starts a really important conversation where I can say, oh, you know what? I noticed you had those 2 medicines. You should only be on one of those. Let's contact your doctor and ask which is the right one, so that we can get you taking the right medicine. So pharmacists actually have saved hundreds and thousands of lives, because since they can see all the medicines that they might catch those double things or things that shouldn't be taken together. And so they're really a great part and resource on your healthcare team. So don't forget to use them.
I love that.
I was going to say, that's something that would go right over my head, or like the thought of reaching out to a pharmacist about my,
would have never done
would have never even thought about it. But I mean, who knows the medication more than them?
No, 100%, 100%. So we've covered a lot of information right now. One thing we kind of started talking about was the commercial plans versus like the private plans. Are these still considered Medicare policies?
Yeah. So the way that Medicare Part C, most people know it as Medicare Advantage, works is basically like the money that, okay, it's going to sound complicated, but it's not.
We're following.
So stay with me.
We're going to break this thing down.
So I'm gonna use round numbers just because it's easier to use round numbers. So say that A and B, that red, white, and blue card, is basically $200 a month in value. Then if you say, oh, I don't want A and B, I want to go with my favorite health insurance that I've had for the last
Blue Cross,
10
Blue
years,
Shield,
Priority Health, Aetna, Cigna, right? Like I want to go with them because I know them. I know the customer service reps. I know that my doctor takes them and likes using them. Then that $200 that was kind of assigned to you from the red, white, and blue card just goes to that health insurance company instead of kind of allotted to you through the government budget. So that's how they get money. And so that's why when you can go on a Part C plan that is called a zero cost plan, because maybe they've built it up in such a way with, you know, the mix of doctors, the mix of hospitals, the mix of medicines, that they were able to fit all of that in that same dollar amount as the red, white, and blue card. So you could have a Medicare Part C plan that looks, again, a lot like what you might be used to as a working person, still for $0 out of pocket every month, because how they built the different pieces of it, they made it so that it wouldn't cost you any extra, because that $200 just got moved over
to the C plan, and it fits what you've already been doing. So like my grandmother's getting older and I'm like, hey granny, so even I can support a family member in this process, and that's where I'm taking this right now. Like if my family member gets to that age, I can look at them like, okay, what do you want? What life do you want? And not, she may not have, it may be overwhelming for her, and I can say, okay, now you can look at the C plan and it'll look exactly what you like, what you're doing now.
You can even tailor it based on the experience that you want.
100%.
So that's amazing.
That actually turns a daunting conversation to more of like a creative, like exciting conversation right now. So that's actually fun, exciting, and progressive to think about.
And so there's plans that can go all the way from $0 to maybe an extra $200 per month. So like the real cost would be $400 if you were paying for it out of pocket. But because that $200 got moved over from the red, white, and blue card, your half is now just $200. And maybe that $200 a month plan that you decided was a good fit, maybe you know you have some surgeries coming up, or you know you have a lot of dental work you'd like to get done. Maybe those things are covered better than the free plan or the lower cost plan, so that your overall out-of-pocket cost is better. So, okay, $200 a month is $2,400 in a year. I know I'm going to get $10,000 in dental work. So it's better for me to do that.
For sure.
Right?
2,400 sounds a lot better.
But if I'm pretty healthy and I don't take a lot of medicines and I don't think I'm going to have any surgeries, that $0 plan might be perfectly perfect for me.
Right.
The idea is to kind of know your health, think about whether your behaviors, because we have so much control over our health. And I think sometimes we forget that, especially when we're in communities where we don't always feel like we have control over our lives. We actually have a lot of control over our bodies.
Through those pillars with the knowledge piece.
Yep. So like what we eat, how frequently we move, what things we drink, whether we go to the doctor on a regular basis and have a relationship so we can ask those questions and push when something isn't exactly right, what medicines we take, how we take them. You know, like we actually have a lot of control.
And that's what taking that inventory and not kind of just pushing things to the side. I mean, I think even for me, like I said, we lean on this youth, but ladies and gentlemen, you still need to take inventory. If you're having a consistent pain or in your shoulder, you feel like you're not getting the right sleep, those are things that will catch up to you. Whether you think it won't or not, it will. So we need to start having these conversations right now. And hopefully with you being competent in your insurance and knowing what you can do, that makes you feel more comfortable to go have that conversation. Because I know a lot of people, they wait till they have to go to the emergency room. We wait. And then we're like, that experience sucks because you're getting hit with a bill based off an emergency or an ambulance cost that could have been a preventable situation. And when I say preventable, not to say things will just never happen, but to say you could have been more aware and it could have been controlled or managed to possibly prevent you from going into the emergency room.
Right.
And if you did go, you'd have a little bit more context to hopefully get a better treatment for yourself. But that's where having these conversations can start, through knowing your insurance and knowing like, hey, I can go to my doctor 3 or 4 times this week if I want to, because I'm only paying $15, $20. So that's $60 for me.
Right.
And not just sitting back and thinking. So I really challenge everyone to take this information and go back and look at your policy. And see what you can do.
Let it enable you.
100%.
Let it enable you.
Yeah. Don't let it paralyze you.
And when the annual enrollment period opens up in late September, early October, there are so many free, trusted, verified sources, places you can go to get help. The area agency on aging. I always mix that up because it's the AAA. The area agency on aging, all together.
Let's say it one more time.
The area agency on aging.
Boom.
Yeah, we did it. That was awesome.
Free promo.
We can put that one in bold letters.
You know, they always have all types of free, really good, verified resource. And so that's a great place that even if they can't help you, they can tell you exactly where to go. The 211 line, the United Way. If you're not sure if you're a senior, or if you're trying to help a senior in your life figure this out, call 211. They'll tell you where you can go to get help figuring this out. You don't have to figure it out by yourself. You just have to be ready to ask some questions and then to like listen to the answers and then use that information to make good decisions.
Yeah. And that's an important piece. I guess I'm kind of thinking now, like, what would be some things that you really want to look at? What are some things that probably are impacting people, but a little bit too late, that may slip past them in the process of choosing an insurance? What's some things that they should have top of mind, or just keep as a thought in general?
So there's 3 things, because as humans, the way that we have evolved and the way that we've built our society, once I get to 5 things, that's too many for you to remember. But 3 is easy to remember. A, B, C, 1, 2, 3,
Trilogies.
all that, right?
100%.
Trilogies, all that. So I'm going to keep it to 3. So the first thing is pay attention to dates and deadlines. Okay. So actually pay attention to when the annual enrollment period is so that you don't miss it. So you don't miss your opportunity to change something, to adjust something. Pay attention to dates. If you have deadlines about when you need to order certain things, when you need to sign certain things, when you need to check if your doctor's going to be part of the insurance plan, pay attention to those dates and deadlines and do your best to meet them. Because once those windows close, you're kind of stuck until the following year.
And that's the truth. We need to know that. You are going to be stuck. This isn't like a soft deadline. This ain't like
it's a literal deadline.
If you forget, we going to still talk to you about it, still make some changes. This is like, it's dead.
Yeah, it's over.
Yeah,
and
it's a wrap.
Like,
we'll see you next year.
We really would like to help you,
but we
cannot.
That's facts. Yeah. That's how serious we got to be.
So pay attention to dates and deadlines.
Okay.
The second thing is, like, do a self-inventory of your body. Sit with your eyes closed in a comfortable spot with your feet on the ground and be like, okay, how is my body feeling? Am I taking medicines? Do I have the right doctors? Do I need a different kind of doctor? Is there something that's been going on with my health that I've been ignoring that maybe I need to pay attention to? How are my teeth doing?
Yeah. Am I feeling sensitive?
Okay?
Yeah.
How is my emotional health, my behavioral health? Have I been feeling sad? Should I think about seeing a counselor or a therapist to help me through the changes of life? Maybe I just retired. Maybe some of the people closest to me are having bad health or even passing away. Do I have the support I need, or should I maybe use the health system to get some more of that support, right? So once you've done your check-in on, what's going on with my body now, what might be going on with my body, what are some things that maybe I'm ignoring that I want to actually do something about the next year or so, then you kind of make yourself a little list. It can be a mental list, but I'll tell you, as I'm getting older, and I'm not that close to 65 yet, if I don't write it down, it didn't happen. So even find that little slip of paper, an old receipt, an old envelope, and just write down a couple of things that are important to you. Like, I know I got some medicines. I know I got to do something about these teeth. And you know what? My foot's been hurting, so maybe I should see a podiatrist, right? And so you just got a couple things on your list. So then when you're starting to shop, either shop for a new plan or make sure that the plan you have is a good fit. You know that you're going to just go and check, okay, is the dental coverage good for what I think I'm probably going to need? Cool. Are the medicines I'm taking now covered, or have I been spending what feels like too much money out of my own pocket and I need something a little bit different? And then if I want to go see a podiatrist, how easy or hard is it for me to see a podiatrist? Can I just call up a podiatrist that I saw 5 years ago for a similar issue and just go? Or do I need to first go to my general practitioner, my PCP, and then let them send me to the podiatrist, and am I okay with that? Or do I want to be able to go directly, right? So that just gives you, instead of having to look through some of these documents, which are hundreds of pages, you can say, well, these are the 3 most important things once I checked in with my body, and then I can shop or adjust based on these most important things.
Okay, prioritizing them.
Yeah, and that also makes it easier. So if you're trying to get help, you're not asking a million questions about a million things. You're asking about the most important things.
Right, you could be more effective in that space. I agree with that. So when we get to that space and we are doing those things and have that list, and you pick up that phone, what type of things are you asking your doctor?
Oh, you can ask.
What type not doctor, your insurance company.
Yeah.
What are you asking them?
You're asking your insurance company. You can say, based on what I have, what might change? If nothing in my health changes, none of my medicines change, none of my doctors change, are my costs changing at all? Just so you know if there's just going to be a change. Because, inflation, year to year, things change. So even if nothing changed with you, something might change with them.
The policy,
so you need to know that. Did something go up? Did something that only cost $20 before now cost $30? Did something that was $0 before now cost $20? Is something that was covered not covered? Are there any changes that are happening? And again, this is one of the things that the government actually does do a really good job at, is there are rules and regulations that say if there is a change to your plan from one year to the next, they have to show you a comparison chart. So you should get in the mail a chart that says, your current plan has this. Next year, this is what's changing. So it's really plain, clear, and simple.
Gotcha.
The other thing you might want to ask is, okay, I think I might want to get more things done. Again, I told you in the example to my dental. I'm having some problems with my mouth. I think I need to spend more time at a dentist to figure out what's going on. So you might say, can you tell me about the dental coverage? I haven't used it a lot, so what do I need to know to be able to get what I think I need to get done with the dentist?
Gotcha.
Do I have to jump through hoops? Is it pretty easy? Can I go to a dentist I used to like? If not, how do I find a dentist? Can you send to the dentist? Do you have a navigator who can be assigned to me? I don't use the internet the same way. My grandkids got me on the iPhone, but I still just make phone calls with it. How do I actually search?
And they'll do that. Stuff? They'll actually have somebody on there that'll walk you through.
And the good news
every piece of this.
So some parts of the system work really well, and this is one of the parts of the system that work well because it's beneficial for both parties. If the health insurance company, if you are healthy, it's better for them because that meant that the money that you gave them every month, they were able to use, and they didn't spend more than their budget. So it's healthy for the health insurance for you to be healthy. So
yes.
Guess what? No, and so they want you to be healthy. If there are things, especially easy things, low-hanging fruit things that they can do to help you be healthy, then they're going to do that.
So they're not just going to send you a bill or
Right.
that, so we can call to talk to these folks.
Yeah, you technically you already paid
You
for
already
it.
are paying
You know
for
how
it.
like when you, and I don't mean to be insensitive because I think you told me you didn't have a degree, so I don't know if you went to college, but like so when you go to college,
2 years.
Okay, good, you went.
Something
okay.
slight.
So when you go to college, you know, something would be like free pizza, free t-shirt. And I used to be like, nah, boo, I paid for this. This is included in my tuition.
Dude, that's the cold hard.
Ain't nothing like free, baby.
Right? And so
this-
actually, like customer service is included in your insurance. So if you're not using customer service, you're actually kind of cheating yourself out of something you
what
paid
did J. Kelly
for.
say? You played yourself, man. Don't play yourself.
If
in
you're
this
not making them
process.
work for you, you're not making them do something that's included.
Oh, 100%.
You're cheating yourself.
Nah,
Yeah,
facts.
that's a good
I
way
hear
to
you
look
now,
at it.
Dr.
That's a good
Bishop.
way to
Don't even
look
worry
at
about that. Hey, it's one thing I've been doing. I ain't played myself. Get on this phone. So I love that. So we went through A, B, C, and D. We've taught you, how to be able to choose the right plan that works for you, how to itemize and prioritize the conversations that you want to have. Dr. Bishop, I knew you was going to come with it. Like I knew you was going to come with it today, but you got heat.
No, I'm hopefully this stuff is helpful.
People. And you're making it easy. Like me and Calvin really just said, like, before this, I told myself, like, man, am I going to study about Medicare and Medicaid so I can actually talk to her about this? Because I feel like it's such at a high level. So I can imagine those out in the community and how they're feeling about that.
Yeah.
And just talking, like, even around my homies and stuff, you don't really talk about, like, insurance.
Right. The same way we don't talk about money. This stuff is kind of taboo. And, so you might hear, oh, well, I haven't been feeling well. But people aren't going to say, I haven't been feeling well and my health insurance you only hear the complaints. But actually, there are actually some really cool parts of our social security, our insurance system that work really, really well.
And they're here to benefit us.
Yeah,
and that's what I'm
especially because it's included.
It's included.
So use it.
Yes, use it.
You're paying for
if
it all.
it's included, use it.
So you know how I said government programs. So little commercial break. So I am very careful about how I say this. So full disclosure, my main job is I work for a health insurance company.
Gotcha.
And some people say public programs, some people say government programs, meaning the same thing, or government funded. But remember, the government don't have no money.
It's ours.
The government don't have no money. And so anything that is a public program or a government program is a program that somehow you pay for. So use it.
Better use it.
Use the parks. Go to City Hall. Go to the free festival because it's not really free. It's included.
It's included. It's already yours.
Take
baby.
advantage.
It's already yours,
is
baby.
what she's trying to say.
No, you're right.
Take
I'm finna be walking head high and proud. You hear me?
Yeah. Like, when's the last time you went
I'm
to
the
a city
CEO
park?
of this public. We all CEOs of this
Yeah.
public event. You know what I'm saying?
No,
This park
for
is all
real.
of ours for real.
If you ever go to
ain't
Washington,
lying.
D.C., you go to Lansing, see the state capitol, that's your building.
Take that picture
Yeah,
proudly.
truly.
Like, look at my
this me.
capitol.
He said selfie that.
That's true. That's a good way to put it. I never even really thought of it like that. So.
We're gonna take a quick segue into Medicaid. I think we did a wonderful job. You did a wonderful job of putting that into perspective for our community. So I want to go into Medicaid now, where we talk through, the benefits of Medicaid and the population that serves, and being able to get them energized to utilize Medicaid, because if it's already included, they should use it.